You go to the hospital because something is wrong. Your body is telling you that something is broken. Your family is scared. You're relying on the doctors, the nurses, the people in the white coats to make things right again. And while you're lying there in that bed, scared and vulnerable and trying to focus on getting better, someone in a hospital gown walks into your room with a stack of papers and asks you to sign your name on the dotted line. They tell you it's just routine. They tell you everyone signs it. They tell you that you can't get treated unless you sign. So you sign. You sign without reading every word because you're sick, you're tired, and you're trusting the people who are supposed to be helping you. But what if I told you that one of those signatures just cost you $15,000? What if I told you that the paperwork they called routine was actually a financial trap, designed by billing experts and hospital administrators to take as much money from your pocket as possible while you were too sick to notice? Today, I'm going to show you the 5 hospital traps that are destroying seniors' retirement savings across America. I'm going to tell you exactly what these documents say, why they're dangerous, what they're really doing to your bank account, and what you can do right now to protect yourself. I'm pulling back the curtain on a system that counts on your trust, your fear, and your exhaustion to steal your signature when you least expect it. This is the video that hospitals and their billing departments do not want you to see. So stay until the very end, because every single minute of this video is going to teach you something that could save you tens of thousands of dollars. And if this kind of information matters to you, please hit that like button right now and share this video with every senior you know, because they need this warning too. Let me take you back to understand how we got here, because this story didn't start yesterday. This is a problem that has been building for decades, and it's getting worse every single year. In the 1980s, American hospitals were relatively simple places. You got sick, you went to the hospital, a doctor treated you, you paid a bill, and everyone moved on. The billing was straightforward. There was a price for the room, a price for the procedure, and that was it. But then something changed. The federal government introduced a new payment system called diagnosis-related groups, or DRGs. Instead of paying hospitals for every single thing they did, the government started paying them a fixed amount based on what was wrong with you. If you came in with pneumonia, the hospital got a set amount of money regardless of how many tests they ran or how long you stayed. That sounds reasonable on the surface, but what it did was it gave hospitals a financial incentive to do more. If they could find additional diagnoses, additional complications, additional reasons to charge more, they could game the system and get paid more money for the same patient. From there, the hospitals got creative. They hired billing specialists. They created complex pricing structures that varied based on insurance contracts, negotiated rates, and a dozen other factors that had nothing to do with the actual cost of care. They discovered that most patients never questioned a bill, especially seniors on Medicare who assumed that the government program was handling everything and they didn't need to worry about the details. And that's exactly when the traps began. The hospitals realized that the admission paperwork, the consent forms, the financial agreements, all of the documents you sign when you're at your most vulnerable, could be designed to extract maximum revenue from every single patient encounter. They embedded authorization clauses that committed you to pay whatever the hospital decided to charge. They buried billing permissions inside consent forms so you wouldn't notice them. They created classifications like observation status that determined whether Medicare would pay for your nursing home care afterward. And they built systems that allowed out-of-network doctors to charge you whatever they wanted, even at hospitals that were supposed to be in your insurance network. Every one of these traps lives inside paperwork that hospitals describe as standard procedure. Every one of them requires your signature to activate. And most seniors sign every single one without ever knowing what they've agreed to. Before we dive into the 5 traps, let me be very clear about something. This is not about attacking hospitals or the dedicated professionals who work in them. There are incredible doctors, nurses, and staff members who genuinely care about their patients and work tirelessly to provide excellent care. This video is about the billing side of healthcare, the administrative layer that has become increasingly sophisticated at extracting money from patients through paper. Work traps. The people who design these traps are not the doctors treating you. They're billing specialists, financial officers, and administrators whose job is to maximize revenue from every patient's signature. And the only way to protect yourself is to understand exactly what you're signing before you sign it. The first trap that seniors fall into is something called an assignment of benefits form, and it is one of the most financially devastating documents you can sign at a hospital. When you arrive at the hospital and they're processing your admission, one of the very first pieces of paper they'll put in front of you is a form that asks you to assign your insurance benefits directly to the hospital. On the surface, this seems completely reasonable. The hospital wants permission to bill your insurance company so they can get paid for the care they're providing. You're assigning the payment to them instead of having the insurance company pay you first. That sounds normal. That sounds fine. But what this document actually does is far more dangerous than it appears, and it's designed to unlock billing rates that you never agreed to pay. Here's the hidden mechanism at work. When you assign your benefits to the hospital, you are giving them the right to receive payment directly from your insurance company. That sounds harmless, but it's actually the first domino in a chain of events that can significantly increase your out-of-pocket costs. What most people don't realize is that hospitals have different billing rates for different categories of patients. If you have not assigned your benefits, the hospital must bill you directly at their standard rate, and then you submit that bill to your insurance company yourself. But when you assign your benefits, the hospital can now bill your insurance company directly, which triggers a whole different set of pricing rules, contracted rates, and fee schedules that may not be favorable to you. In many cases, the contracted rates that hospitals use for insurance company billing are actually higher than the cash rates that would apply if you were paying out of pocket. The insurance company pays a portion of that higher rate, and you are responsible for the remainder, which is also calculated based on the higher contracted rate. Let me break this down with a real number example so it's crystal clear. You go to the hospital for a diagnostic procedure. The hospital's actual cost for the procedure is $2,500. If you have not signed an assignment of benefits, the hospital bills your insurance company at their standard rate of $3,500. Your insurance has a contract with the hospital, so they agree to pay $3,000, leaving an $800 patient responsibility that gets billed directly to you. Not great, but manageable. But when you sign the assignment of benefits, the hospital now has the ability to use a different billing classification. They can access rates from their contracted facility pricing structure, which allows them to charge $4,500 for the same procedure. Your insurance pays $4,000 because of the way the contracted rates work, and you're responsible for the remaining $500. But wait, it gets worse. Because the assignment of benefits also shifts your cost-sharing calculation. Instead of your $800 copay being based on the lower billing rate, your $500 copay is now based on the higher contracted rate. And your insurance may have different rules about what percentage of charges they'll cover when the benefits are assigned versus when they're not. This is extremely confusing, and that's by design. The hospitals have created billing structures that are so complex that even insurance agents and benefits managers struggle to understand them. But the bottom line is simple. When you sign an assignment of benefits, you are giving the hospital permission to use billing classifications and pricing structures that may result in significantly higher costs for you, the patient. And here's what makes this trap so insidious. You are asked to sign this form at the very beginning of your hospital visit, often before you know what procedure you're having, what tests will be run, or what your total bill will be. You are being asked to authorize a billing structure for services you haven't even received yet. The state-by-state differences in how assignment of benefits works are significant, and understanding them can help you know whether the form you're signing is more dangerous in your state than in others. In California, hospitals are required by law to provide patients with a written disclosure of estimated charges before providing non-emergency services in many circumstances. This means that if you're signing an assignment of benefits in California, you should be able to request the hospital's estimated charges in WR. Eating before you sign anything. California also has specific rules about how financial forms must be presented, which means the assignment of benefits cannot be buried in a stack of other documents and must be clearly identified as a financial authorization. In New York, patients have stronger protections against surprise medical bills, particularly in situations where they receive care from providers at in-network facilities who are themselves out of network. New York's balance billing protection law specifically addresses situations where the assignment of benefits might trigger out-of-network charges, and it provides patients with some recourse when that happens. In Texas, the rules around assignment of benefits are less protective, and hospitals have significant latitude in how they structure these agreements and what billing rates they can access through them. Florida has some of the most permissive assignment of benefits rules in the country, which has led to aggressive billing practices by Florida hospitals, particularly in the years following major hurricanes when hospitals were dealing with high volumes of patients and used assignment forms to access emergency pricing structures. In Washington state, there are specific consumer protection laws that require hospitals to clearly disclose the financial implications of assigning benefits, and patients have the right to request itemized billing before charges are finalized. Here's what you need to do. When the hospital asks you to sign an assignment of benefits, do not sign it immediately. Ask the person presenting the form whether you are required to sign it in order to receive treatment. In most non-emergency situations, the answer is no. You can decline to assign your benefits and instead request that the hospital bill you directly, at which point you can forward the bill to your insurance company yourself. This is called direct billing, and it gives you more control over the pricing structure that applies to your care. If the hospital insists that you must sign the assignment form, ask to speak with a financial counselor and request a written explanation of exactly what charges will apply with and without the assignment. Get that explanation in writing before you sign anything. And remember, you always have the right to say no to a document you don't understand. No hospital can legally deny you emergency care if you decline to sign a financial form. If they tell you otherwise, that is a violation of federal law. If you're just joining us and you found this video valuable, please hit that like button. This is exactly the kind of information that hospitals don't want you to have. When you like a video, the YouTube algorithm shows it to more people, which means more seniors can protect themselves from these billing traps. And if you haven't subscribed yet, please do it now. Every week I'm pulling back the curtain on the financial traps that are stealing seniors' retirement savings, and you need to be here for every episode. Hit the subscribe button and turn on notifications so you never miss a warning. The second trap is one that catches seniors more frequently than any other hospital a PERWORK Chinese letter, and it's hiding inside what looks like one of the most innocent documents in the entire stack. I'm talking about the general consent to treatment form. When you go to the hospital, they hand you a consent form that says something like, "I consent to examination and treatment by the hospital staff and affiliated providers." That sounds completely reasonable. You went to the hospital, you want to be examined and treated, so you sign the form. But what they don't tell you is that buried inside that consent form is language that goes far beyond simply consenting to medical care. These consent forms have been carefully designed by hospital legal departments to include billing authorizations, financial obligations, and agreements to pay for services you may not even know were provided. Here's the hidden mechanism. Most consent forms include language that gives the hospital permission to provide and bill for additional services as deemed medically necessary by hospital staff or affiliated providers. That phrase is the key to the trap. It means that if the hospital decides on their own without telling you that you need a test, a consultation, a procedure, or a medication, they can provide it and bill you for it, and your signature on the consent form serves as your agreement to pay for all of it. You never had a conversation with a cardiologist, but a cardiology consult was medically necessary. You never met a nutritionist, but a nutritional assessment was medically necessary. You never saw a physical therapist, but a PT evaluation was medically necessary. And because you signed the consent form, you agreed to pay for all of it, whether you wanted it or not. Let me give you a real case study. A man in his 70s went to the hospital for a MR outpatient procedure. He was fully conscious, alert, and capable of making decisions, but he was nervous and wanted to get the procedure done so he could go home. The nurse handed him a stack of papers and told him they were standard admission forms. He signed them without reading them closely. The procedure took 20 minutes. He went home. 3 weeks later, he received a bill for $11,000. When he asked for an itemized bill, he discovered that the hospital had charged him for a cardiac evaluation, a pulmonary function test, a psychiatric screening assessment, a nutritional consultation, and a physical therapy evaluation. He had never seen any of these providers. He had never been told these services were being performed. He had never given specific consent for any of them. But because he had signed the general consent to treatment form, the hospital argued that he had agreed to all of these services under the medically necessary clause. This is happening every single day in hospitals across America. The consent form is being used as a billing blank check, and seniors are the primary targets because they are more likely to sign documents without reading them, more likely to trust hospital staff, and more likely to assume that the billing will be handled correctly by Medicare or their insurance company. But here's the truth they don't tell you. Medicare and insurance companies do not automatically review every charge on a hospital bill to determine if it was actually provided or actually necessary. They rely on the hospital's documentation and your signed consent form as proof that all of the billed services were agreed to and provided. So when you sign that general consent form, you're not just consenting to treatment. You're giving the hospital a legal document that says, "I agree to pay for whatever you decide to do to me, whether I know about it or not." The state laws around consent forms are varying significantly, and this is one of those areas where state regulations can either protect you or leave you vulnerable. In California, the informed consent laws specifically require that patients be given information about what procedures and services will be performed, and the consent must be specific to those services. A general consent form that authorizes additional services without the patient's knowledge or specific agreement may not meet California's informed consent standards. Massachusetts has very strong informed consent requirements that specifically require physicians and hospitals to explain what procedures will be performed and obtain specific consent for them, making it harder for hospitals to use broad consent language to justify billing for services the patient never agreed to. In Connecticut, there are specific disclosure requirements that apply to hospital consent forms, and any clause that attempts to authorize services beyond what was explained to the patient must be specifically called out and explained. In Florida, the consent form laws are far less restrictive, and Florida hospitals have been particularly aggressive in using broad consent language to justify charging for additional services. Florida's combination of permissive consent laws and aggressive billing practices has made it one of the worst states for seniors who are trying to protect themselves from unexpected hospital charges. The counterargument that hospitals and their billing departments make is that these additional services are often genuinely medically necessary, and without the ability to provide them under a general consent, they might miss important health issues that could put patients at risk. They argue that requiring specific consent for every single service would delay care and potentially harm patients, and there's some truth to that concern. In emergency situations, requiring specific consent for every test and treatment could be dangerous. But here's what the hospitals don't tell you. For non-emergency situations, which is what most admissions are, you absolutely have the right to limit the scope of your consent. You can sign a consent form that specifically authorizes the procedure you're having and explicitly excludes additional services unless you are specifically informed and provide specific consent for each one. They just don't tell you that option exists because they make more money when you sign the broad form. Here's your step-by-step protection plan for consent forms. First, read every single page of any consent form before you sign it. Yes, it's long. Yes, it uses complex legal language, but your signature is your financial commitment, and it's worth the time it takes to read it. Second, look specifically for language about additional services, medically necessary services as determined by the hospital, or any clause that gives the hospital discretion over what services to provide and bill for. Third, if you see that language, do not simply sign the form as is. CR. Cross out the problematic language, write your initials next to the crossout, and add a specific statement that says, "I do not consent to additional services beyond the specifically described procedure without my specific written approval for each service." Fourth, if the hospital tells you that you cannot modify the consent form, ask to speak with a patient advocate or the hospital's legal department. Get their refusal to allow modifications in writing. That written refusal is documentation that you attempted to limit your consent and were prevented from doing so, which can be valuable if you later receive bills for services you didn't agree to. Let me ask you something in the comments. Have you ever been charged for a hospital service that you didn't know was performed? What did you do when you saw the charge? Your story helps other seniors recognize that they're not alone in this experience, and it gives them the courage to speak up and challenge their bills. Please share your experience in the comments below, and if you found this information helpful, please share this video with someone you know who might need to hear this warning. The third trap is one that has become an epidemic in American hospitals, and it is specifically targeting seniors on Medicare in a way that is costing them billions of dollars collectively. I'm talking about the observation status designation, And this is perhaps the sneakiest billing trap in the entire healthcare system, because most seniors don't even know it exists until they're staring at a bill they didn't expect and a nursing home cost that Medicare won't cover. Here's how it works. When you go to the hospital, there are two ways the hospital can classify you. You can be admitted as an inpatient, which means you're officially a patient in the hospital and Medicare Part A covers your stay. Or you can be placed under observation status, which means you're technically still classified as an outpatient even though you're living in a hospital bed, receiving hospital meals, and seeing hospital doctors. The hospital stay feels exactly the same whether you're an inpatient or under observation. The care you receive is exactly the same, but the billing and the coverage rules are dramatically different. Here's why observation status is such a devastating trap. When you're admitted as an inpatient, Medicare Part A covers your hospital stay with a set deductible that applies to the first benefit period. The rules are relatively straightforward, and there's a defined cost structure. But when you're under observation status, Medicare Part B applies, which means you're responsible for 20% of the cost of every single service, every test, every medication, and every procedure. The hospital can charge you for each individual item separately, and Medicare pays 80% of each charge while you pay 20%. That might not sound like a huge difference, but when you add up all the individual charges over a multi-day hospital stay, the out-of-pocket costs under observation status can be 2, 3, or even 4 times higher than they would be under an inpatient admission with Part A coverage. But here's the real killer. There's a Medicare rule called the 3-day rule that requires you to have been admitted as an inpatient for at least 3 consecutive days before Medicare will cover your care in a skilled nursing facility afterward. This is critically important. If you spend 5 days in the hospital under observation status, and then your doctor recommends that you go to a skilled nursing facility for rehabilitation or ongoing care, Medicare will not cover the nursing home because you weren't admitted as an inpatient for 3 days. You were an outpatient under observation status, and Medicare Part B does not cover skilled nursing facility care. So now you're looking at nursing home costs of approximately $6,000 to $8,000 per month, and all of that money comes directly from your own pocket. That 5-day observation stay has just cost you potentially hundreds of thousands of dollars over the coming months or years of nursing home care that Medicare would have covered if you had been properly admitted as an inpatient. Let me run the complete numbers so you understand the true financial impact. You go to the hospital and spend 6 days under observation status. The hospital charges a total of $25,000 for your stay under Part B billing rules. Medicare pays $20,000, and you're responsible for the remaining $5,000. That seems manageable in isolation. But when you're discharged, your doctor says you need to go to a skilled nursing facility for physical therapy and rehabilitation because you're not strong enough to go home yet. The nursing home costs $7,000 per month. Without the 3-day inpatient admission, Medicare won't cover any of it over the course of a 6-month NER. Sing home stay, you're looking at $42,000 in out-of-pocket costs. That 6-day observation stay has now cost you a total of $47,000 out of your own pocket. If you had been admitted as an inpatient for 3 days, Medicare would have covered the nursing home, and your out-of-pocket costs would have been a small fraction of that amount. The state-by-state breakdown for observation status is interesting because this is primarily a federal Medicare issue rather than a state regulatory issue. However, research has shown significant variation in how aggressively different hospitals use observation status, and that variation tends to be consistent within certain regions and hospital systems. Teaching hospitals and academic medical centers tend to use observation status more frequently than community hospitals because it allows them to manage their patient census and avoid the more stringent regulations that apply to admitted inpatients. Rural hospitals sometimes use observation status as a way to keep patients in the hospital without triggering the more expensive inpatient classification, particularly when they're uncertain about how long a patient will need to stay. The variation is more about hospital system practices than state regulations, which means the protection isn't in your state's laws, but in your ability to question your classification while you're still in the hospital. The hidden trigger for this trap is exactly what makes it so dangerous. You don't know you're under observation status while it's happening. The hospital doesn't prominently announce that you've been placed under observation status rather than admitted as an inpatient. The classification is made by a doctor and documented in your medical record, but you're never told about it unless you specifically ask. Many seniors find out they were under observation status only when they receive their Medicare summary notice weeks later and see that their hospital stay was billed under Part B instead of Part A by that point. The 3-day inpatient window has closed, and there's nothing you can do to change the classification retroactively. That's why the timing of this trap is so critical. You have to know to ask about your classification while you're still in the hospital, not after you've been discharged. Here's what you must do every single time you go to the hospital. Step 1. Ask the attending physician or the hospital admissions staff whether you have been admitted as an inpatient or placed under observation status. Step 2. If they say observation status, ask them to explain exactly why and whether they can change your status to an inpatient admission. Step 3. If they cannot or will not change your status, ask them to document in your medical record that you were under observation status, that you were informed of this classification, and that you understood the financial implications, including the fact that observation status does not count toward the 3-day inpatient requirement for Medicare skilled nursing facility coverage. Step 4. When you're discharged, if you need skilled nursing facility care and you don't have the 3-day inpatient admission, contact Medicare immediately to file an appeal. The appeals process has successfully reversed observation status classifications in many cases, particularly when the hospital failed to properly inform the patient of their status or failed to document the medical justification for observation versus inpatient classification. This next point is critically important. Hospitals are required to provide you with something called a Medicare Outpatient Observation Notice when you've been under observation status for more than 24 hours. This notice must be provided to you orally and in writing, and it must explain that you are an outpatient, not an inpatient, and that this status affects your coverage for nursing home care. If you did not receive this notice, that is a violation of federal law, and it can be used as part of your appeal. Keep track of everything the hospital tells you about your status, and get all communications in writing whenever possible. Hit that like button right now if you're learning about the observation status trap for the first time. This is the kind of information that can mean the difference between a manageable hospital bill and a financial catastrophe that wipes out your retirement savings. And please share this video with every senior you know, because most of them have no idea that their hospital classification could cost them hundreds of thousands of dollars. The fourth trap is one that has exploded across the American healthcare landscape over the past decade, and it's specifically designed to extract more money from seniors who have ongoing relationships with their doctors and regular healthcare needs. I'm talking about hospital-issued provider-based billing, also known as facility fees. TH. This is a billing practice where the hospital charges you a facility fee on top of the professional fee you pay to the doctor, and it's appearing in more and more places where seniors receive their care. Here's the mechanism. Hospital systems across America have been rapidly acquiring independent physician practices. Your family doctor, your cardiologist, your dermatologist, your orthopedist, any medical practice you can think of, is increasingly likely to be owned by a large hospital system rather than independent. When a hospital system owns a medical practice, they can then charge a facility fee every time you receive care at that practice. The doctor's professional fee covers the actual medical service. The facility fee is supposed to cover the cost of running the facility, maintaining the building, providing the infrastructure, and other overhead costs. Sounds reasonable, right? But here's what they don't tell you. Those facility fees can be enormous, and they don't exist at independent physician practices. If you see the same doctor at their independent office, you pay one fee. If you see the same doctor at a hospital-owned office, you pay 2 fees, and the second fee can be 2, 3, 4, or even 5 times the amount of the first fee. Let me give you a real example. A woman in her 60s had been seeing the same cardiologist for 15 years. The cardiologist's practice was independent, and her office visits cost $150 with her insurance. Her copay was $30, simple, straightforward. Then the hospital system acquired the cardiology practice. Overnight, nothing changed in terms of the doctor, the staff, the care, or the building, but the billing changed completely. Now, every office visit included a facility fee of $220 in addition to the professional fee of $150, for a total charge of $370. Her insurance processed the claim at the hospital outpatient department rate instead of the physician office rate. Her copay went from $30 to $74, and that was just the beginning. Because the facility fee was billed separately, it triggered a different cost-sharing calculation under her insurance plan, which meant she was responsible for a larger percentage of the total charges. What used to be a $30 copay became a $112 out-of-pocket cost per visit, and that extra $82 per visit multiplied across 12 visits per year added up to nearly $1,000 in additional costs per year just for seeing the same doctor. The reason this trap is so effective is that most seniors don't realize the acquisition happened. When a hospital system buys a medical practice, they typically keep the same office location, the same staff, the same doctors, and the same phone number. You walk into what looks and feels like the same office, see the same doctor, receive the same care, but the billing structure has completely changed. And because the facility fee is charged separately from the professional fee, it often appears on your insurance statement as a different line item, which means it might not be immediately obvious that you're paying more than you were before. The state laws around facility fees are some of the most important consumer protections available, but they vary dramatically from state to state. In Colorado, there are specific laws that limit when hospitals can charge facility fees and require hospitals to clearly notify patients when a facility fee will be applied before services are rendered. Colorado's facility fee disclosure law is one of the strongest in the country and gives patients the opportunity to make an informed decision about where to receive care. In Connecticut, legislation has been passed that specifically prohibits facility fees for outpatient services provided at off-campus physician office locations that were previously independent practices. Connecticut recognized that hospital acquisition of physician practices was being used as a mechanism to introduce facility fees for routine care that patients had been receiving for years at much lower costs, and they passed the law to stop it. In New York, there are disclosure requirements that force hospitals to notify patients about facility fees before services are rendered, and patients have the right to ask about facility fees before scheduling an appointment. But in many other states, particularly in the South and the Midwest, facility fees are largely unregulated, and hospital systems can charge them for virtually any service at any location they own. States like Georgia, Alabama, and Mississippi have some of the least restrictive facility fee regulations in the country, which has made them particularly attractive targets for hospital system acquisitions of independent practices. The counterargument from hospital systems is that facility fees are necessary to cover the true cost of care at hospital-owned facilities, which have higher overhead, stricter regulatory requirements, and more comprehensive infrastructure than independent physician offices. They argue that patients receive the same care and that the facility fee reflects the higher standard of the hospital environment. But here's what they don't tell you. When a hospital acquires an independent practice and charges facility fees, they're charging those fees for care that was previously provided at a lower cost without facility fees. The physical location hasn't changed. The doctor hasn't changed. The equipment hasn't changed. The only thing that has changed is the billing structure, and it's designed to extract more money from patients and insurance companies by rebranding a routine doctor visit as a hospital outpatient service. Here's your step-by-step protection plan. Step 1. Before you schedule any appointment with a specialist or your primary care doctor, ask whether the practice is owned by a hospital system. You can usually find this information on the practice's website or by calling the office directly. Step 2. If the practice is owned by a hospital system, ask specifically whether facility fees will be charged for your visit and how much those fees will be. Step 3. Ask your insurance company whether the facility fees will be processed under your medical benefit or your hospital benefit, because that determination affects your out-of-pocket costs significantly. Step 4. If facility fees apply and they're substantial, ask your insurance company for a list of independent physician practices in your area that provide the same specialty services without facility fees. Step 5. Consider switching to an independent provider if the cost difference is significant enough to affect your budget. Your insurance company may even have financial incentives to help you find independent providers, so ask them specifically about this. Please share your experience with facility fees in the comments below. Have you ever been charged a facility fee at a doctor's office that didn't look like a hospital? What was the amount, and how did you handle it? Your story helps other seniors know what to look for and what questions to ask. And if you're finding this information valuable, please hit the like button and subscribe to this channel, because there's one more trap coming up that's the most dangerous of all. The fifth and final trap is the one that costs seniors more money every single year than all the others combined. And it's one that most seniors don't even know exists until they're sitting at their kitchen table staring at a bill for tens of thousands of dollars. I'm talking about the out-of-network trap, and it is a billing practice that is quietly destroying the financial security of seniors across America. Here's how it works. You go to a hospital that is in your insurance network. You check before you go. You confirm that the hospital accepts your insurance. You show up, you get registered, you sign the admission paperwork, and you trust that you're covered because the hospital told you they accept your insurance. But here's the brutal truth that hospitals don't make clear to you. Just because the hospital is in your network does not mean that all of the doctors who work there are in your network. Many hospitals, even so-called in-network hospitals, hire independent contractors, specialists, and consulting physicians who do not participate in the same insurance plans that the hospital accepts. And when you sign those admission forms, you're often agreeing that you will pay whatever these out-of-network providers charge, even if you didn't know they were out-of-network, didn't choose them, and had no way to avoid using them. Here's how this plays out in a real hospital stay. You go to the hospital for a surgical procedure. The hospital is in your insurance network, so you're told you're covered, everything looks good. But during your surgery, an anesthesiologist provides your anesthesia. That anesthesiologist is an independent contractor who does not accept your insurance. You had no idea. You couldn't have known. You were unconscious. Then, after the surgery, a pathologist examines your tissue samples. That pathologist is also an independent contractor and out of network. A radiologist reads your imaging, also out of network. An assistant surgeon participates in your procedure, also out of network. You never met any of these people. You never chose any of them. You had no say in who would be in the operating room. But when the bills arrive, you're responsible for all of them because they're out of network. And you signed a document agreeing to pay for whatever services the hospital and its providers decided to render. Let me run the numbers for you. Your surgery itself is covered by your insurance at an in-network rate, but the anesthesiologist sends you a bill for $9,500. Red dollars. Your insurance says they'll pay $1,000 because the provider is out of network, leaving an $8,500 balance for you to pay. The pathologist sends you a bill for $3,200. Your insurance pays $800, leaving a $2,400 balance. The radiologist sends you a bill for $4,100. Your insurance pays $900, leaving a $3,200 balance. The assistant surgeon sends you a bill for $7,800. Your insurance pays $1,500, leaving a $6,300 balance. Your surgery went perfectly. Your doctors did an excellent job. But you now owe over $20,000 in out-of-network charges that you never expected and couldn't have avoided. This is not a hypothetical scenario. This is happening to thousands of seniors every single month across America. The state laws around out-of-network billing are some of the most important consumer protections available, and they've been evolving rapidly over the past several years. In California, the No Surprises Act implementation provides strong protections against surprise out-of-network bills, particularly for emergency services. California also has its own state-level surprise billing law that provides additional protections beyond the federal law. In New York, the balance billing law is one of the strongest in the country. It specifically prohibits healthcare providers from billing patients for the difference between what they charge and what insurance pays when the provider is out of network, and the patient had no choice in selecting the provider. New York requires that patients be given clear notice when a provider is out of network, and that they have the opportunity to consent or decline to out-of-network services in non-emergency situations. Texas has strong protections against surprise billing, particularly in emergency situations where patients have no ability to select their providers. Texas law requires that out-of-network providers at in-network facilities bill at the in-network rate, with the difference absorbed by the provider rather than passed on to the patient. But in many other states, the protections are significantly weaker, and seniors are far more vulnerable to these out-of-network traps. States like Arkansas, Missouri, and Louisiana have weaker balance billing protections, and out-of-network charges at in-network hospitals are more likely to be passed directly to the patient. The Federal No Surprises Act that took effect in January 2022 provides some national protections, but it has significant gaps that hospitals and their billing departments are actively exploiting. The No Surprises Act protects patients from surprise bills for emergency services and for certain scheduled procedures where the patient had no way to know the provider would be out of network. But the law does not cover ground ambulance services, which means you can be hit with massive out-of-network bills for ambulance rides even if the hospital itself is in network. The law also has gaps in coverage for certain types of specialist care, and hospitals have found ways to structure their billing to fall outside the law's protections. Additionally, the No Surprises Act's protections are currently being challenged in court by healthcare industry groups who want to weaken the regulations, and the future of those protections is uncertain. Here's your complete step-by-step protection plan for out-of-network billing. Before any planned procedure, Step 1, call your insurance company and confirm that the hospital is in network. Step 2, ask your insurance company which specific providers will be involved in your procedure and whether those providers are in network. Get the names of the surgeon, the anesthesiologist, any assistant surgeons, the pathologist, the radiologist, and any other specialist who might participate. Step 3, call each provider's office individually to confirm their network status with your specific insurance plan. Do not assume that because one person in the practice is in network, everyone is in network. Step 4, if you discover that any provider is out of network, ask the hospital if they can substitute an in-network provider. Hospitals can often arrange for in-network specialists, but they won't do it unless you ask. Step 5, if substitution isn't possible and you must proceed with an out-of-network provider, contact your insurance company to understand exactly what they will and won't pay, what your cost sharing will be, and what your options are for negotiating the charges. Step 6, if you receive an unexpected out-of-network bill, do not pay it immediately. File an appeal with your insurance company and contact your state's insurance commissioner to report the charge. In many cases, the appeals process and regulatory intervention can successfully reduce or eliminate surprise out-of-network bills. Let me be very clear about something. You should not avoid necessary medical care because you're worried about out-of-network charges. Your health is far more important than a billing issue, but you should be informed about the potential costs so you can plan for them and challenge them appropriately. Hospitals and their billing departments count on seniors being too overwhelmed by health issues to question the bills they receive. Do not give them that advantage. Question everything. Challenge everything. And never pay a bill you don't understand without first getting a detailed explanation in writing. Hit that like button right now if you're learning about out-of-network billing traps for the first time. This is the trap that is costing seniors an average of thousands of dollars per incident, and most seniors don't even know it exists until they're already holding the bill. If you want to protect yourself and your family, please share this video with everyone you know. Knowledge is the only defense against these predatory billing practices. Now I want to talk about what's coming in 2027 and beyond, and why understanding these 5 hospital traps is more important right now than it has ever been before. There are converging trends in the healthcare industry that are going to make these traps even more dangerous and even harder to escape in the coming years. And seniors need to understand what's coming so they can protect themselves before it's too late. The first major trend is hospital consolidation. Hospital systems across America are acquiring physician practices, outpatient clinics, imaging centers, and specialty practices at an accelerating rate. Every time a hospital acquires a practice, facility fees begin applying to services that previously didn't have them. Every time a hospital buys a doctor's office, patients start paying more for the same care from the same doctor. This consolidation trend is being driven by financial incentives in the healthcare system, and it's not slowing down. By 2027, it's estimated that the majority of physician practices in many specialties will be owned by hospital systems rather than independent physicians. That means more seniors will be receiving care at hospital-owned facilities without realizing it, and more seniors will be paying facility fees on every visit. The second major trend is insurance network contraction. Insurance companies are tightening their provider networks to control costs, which means fewer doctors and hospitals are in network for any given insurance plan. The tighter networks make it more likely that patients will encounter out-of-network providers at hospitals that appear to be in network. The insurance companies know this is happening. They're not fixing it because it saves them money. When you get a surprise out-of-network bill, your insurance company only pays a small portion of it, and the rest falls on you. That means the insurance company's actual out-of-pocket cost is lower than it would be if they maintained broader networks. So the insurance companies have a financial incentive to keep networks tight, which means the out-of-network trap will get worse before it gets better. The third major trend is the ongoing legal challenges to consumer protection laws. The No Surprises Act is currently being challenged in court by healthcare industry groups who want to weaken its protections. If those challenges succeed, the most significant federal protection against surprise billing could be significantly weakened or eliminated. That would leave seniors relying on state-level protections, which are inconsistent and often inadequate. The regulatory landscape for hospital billing is constantly changing, and the direction of that change tends to favor hospitals and their billing departments, not patients. The fourth major trend is the increasing sophistication of hospital billing systems. Hospitals are using artificial intelligence and machine learning tools to identify opportunities to add charges, maximize reimbursements, and capture billing classifications that result in higher revenue per patient. These systems are specifically designed to find the cracks in insurance coverage, the gaps in patient consent, and the moments when patients are too sick or too overwhelmed to question what's happening. The traps I've described in this video are not accidental. They're not the result of billing errors or miscommunications. They are deliberate, carefully designed financial mechanisms that generate billions of dollars in additional revenue for hospitals every year by exploiting patients who don't know the rules. I'll see you in the next video where I'm going to reveal another financial trap that's quietly draining seniors' bank accounts across the country. Make sure you're subscribed, because the next trap might be the one that saves everything you've worked. Your entire life to build. Stay alert, stay informed, and most importantly, stay in control of your own financial future. You've earned your retirement. Don't let a stack of hospital paperwork take it away from you.